Okay, we'll continue with the part 3 of hemolytic anemias, which is thalassemias. Hemoglobinopathies are genetically determined. Abnormality of the structure or synthesis of the hemoglobin molecular are called as hemoglobinopathies. It can be quantitative or qualitative. So, we'll deal with thalassemias. Thalassemias are heterogeneous group of genetic disorders of hemoglobin synthesis where you see decreased or absent synthesis of globin chains. It can be quantitative abnormalities of the globin chain synthesis. The consequences are reduced intracellular hemoglobin and excess of abnormal globin molecules. Molecular pathology. The normal adult hemoglobin contains three types of hemoglobin. The major component is adult hemoglobin, which is alpha 2, beta 2. The minor component is fetal hemoglobin, which is alpha 2, gamma 2, and adult hemoglobin A2, that is alpha 2, delta 2. The structure and synthesis of the hemoglobin adults is it contains 96 to 98% of the adult hemoglobin, that is alpha 2, beta 2, and 1.5 to 3.2% of adult hemoglobin, which is HbA2, which is alpha 2, delta 2. And then there is 0.5 to 0.8% of the fetal hemoglobin, which is alpha 2, gamma 2. Coming to molecular pathogenesis, each alpha chain is encoded by two genes present on the chromosome 16. So it contains 4 genes per cell, which is coding alpha globin chain. Each beta chain is encoded by single gene on chromosome 11. That's why it contains 2 genes per cell, which is encoding the beta globin chain. On chromosome 11. It can be inherited as autosomal codominant condition. It can be heterozygous form, which is called as thalassemia minor or trait. It can be otherwise homozygous form, that is thalassemia major. The beta thalassemia is caused by deficient synthesis of beta globin chain, and alpha thalassemia is due to deficient alpha chains. So basically in beta thalassemia you see excess of alpha chains, and in alpha thalassemia you see excess of beta chains. And this leads to hematological consequences are due to low intracellular hemoglobin and relative excess of unimpaired chains. This further leads to ineffective erythropoiesis in the bone marrow and extravascular hemolysis in spleen. These syndromes are a group of disorders with decreased production of alpha or beta chains, as I already mentioned. The features would be they'll have low hemoglobin depending on the type of the hemoglobinopathy. They'll have microcytic hypochromic RBCs. Unlike iron deficiency anemia, you can see uniform to low red cell distribution width. You can see target forms which are typically seen in the peripheral pool, no pencil forms. Heinz bodies are seen, which are because of the globin deposit. HbH inclusions are seen. Beta thalassemia, the variation in the clinical syndromes due to heterogeneity in mutations of beta globin gene. The terminologies which are used are beta thalassemia, where there is total absence of the beta chains, beta plus, which implies reduced but detectable beta chains, and beta implies normal amount of beta chains. Around 100 mutations have been revealed to cause beta thalassemia. The impaired beta chains leads to underhemoglobinized microcytic hypochromic RBCs. Excess of unpaired alpha chains cause precipitation and form insoluble inclusions in the RBC. Many RBCs in the marrow undergo apoptosis. The inclusion bearing cells undergo culling and pitting in spleen due to decreased deformability and hence leads to extravascular hemolysis. Because of the anemia, there is marked erythropoietin secretion by the kidney. This leads to massive erythroid hyperplasia and extramedullary hematopoiesis. So this erythroid hyperplasia can be ineffective, leading to the expansion of the bone marrow in other bones like skull, cheekbones, and the maxilla, leading to expansion of the bone marrow over there, and then formation of new bone on the outer surface, leading to crew cut or hair on end appearance, which is typically seen in thalassemic facies. This further leads to impairment of the bone growth and skeletal abnormalities. Liver, spleen, lymph nodes may enlarge due to work hyperplasia. And due to excessive dietary absorption of the iron, patients can end up with hemochromatosis or hemochromatosis because of the repeated transfusion therapy which is given in thalassemia. Clinical and genetic classification of the beta thalassemia. It can be clinically classified as thalassemia major, thalassemia intermediate, and thalassemia minor. Thalassemia major can be homozygous or it can be homozygous B0 or homozygous beta plus, where beta 0 is where all the beta globin chains are absent. Homozygous B plus is where it can be deficient. This leads to severe type of thalassemia which requires blood transfusion. Thalassemia intermediate is severe but no regular transfusion. It can be beta 0 beta or beta plus beta plus. Thalassemia minor can be beta 0 or beta, asymptomatic or mild, or absent anemia. Uh, This is also called as Mediterranean anemia or Cooley's anemia, which is seen in Africa and Southeast Asia. Anemia manifests by around 6 to 9 months after birth, and when the switchover from the fetal hemoglobin to adult hemoglobin occurs. Average hemoglobin content is 3 to 6 gram percent. Peripheral smear you see anisocytosis and poikilocytosis, microcytic hypochromic RBCs, target cells, basophilic stippling, and fragmented RBCs. This is the distribution. Reticulocyte count is elevated but below expected due to ineffective erythropoiesis. Fetal hemoglobin is increased. Adult fetal HbA2 levels can be normal, low, or high. Expansion of the facial bones, I mentioned already, it leads to crooked appearance or hair on end appearance. This is because of the expansion of the marrow in the cortex, as well as there is new bone formation in the outer surface. Patients can have splenomegaly, and they have hemositus hemochromatosis because of the repeated blood transfusion as a therapy, and they can have organ dysfunction. This is what you see in the skull bone. There is expansion of the cortex by bone marrow hyperplasia. This is X-ray picture where you can see hair on end appearance. Right? It appears like hair there. So this is the new bone formation seen on the outer surface. The patients can present with growth retardation, death at early age, and so transfusion dependent anemia needs regular iron chelation. Bone marrow transplantation is the ultimate treatment of choice. Prenatal diagnosis is possible by molecular DNA analysis. This is the peripheral blood picture where you can see macrocytic hypochromic RBCs and target cells and nucleated RBCs. Beta thalassemia minor is much more commoner than the major. Resistance to they'll have resistance to falciparum infection. They can range from asymptomatic and they can have mild anemia. Microcytic hypochromic RBCs are seen. Target cells are seen in the peripheral pool. Hemoglobin electrophoresis reveals increased adult hemoglobin. Fetal hemoglobin is normal or slightly increased. Detection of this is important to rule out iron deficiency anemia, and genetic counseling for the prospective mothers can be done. This is a peripheral pool picture where you can see target cells and microcytic hypochromic RBCs. Alpha thalassemia is the severity of the alpha thalassemia varies depends upon the number of genes affected. So anemia is due to lack of adequate hemoglobin and excess of beta, gamma or delta genes. So normal fetal hemoglobin is alpha 2, gamma 2. So the newborn with severe alpha thalassemia where all the 4 genes are absent leads to gamma 4, that is hemoglobin bards, leading to hydrops fetalis. Adult patient with severe alpha thalassemia is beta 4, which is HbH disease. Both BARDs and HbH are soluble, and ineffective erythropoiesis is mild in alpha thalassemia. Clinical and genetic classification of alpha thalassemia, you can see hydrops vitalis where there is complete absence of all the alpha genes, which is lethal in utero, that is gamma 4. HbH is where one alpha gene is absent, which is severe, resembles beta intermedia. Alpha thalassemia trait is asymptomatic, resembles beta minor, where 2 genes are absent. Silent carrier is only 1 gene is absent, there is no red cell abnormality. The same thing, alpha thalassemia trait, deletions of 2 alpha globin chains, it can be Asian or African, no abnormal physical signs, no or minimal anemia. HbH is seen in adults where there is deletion of 3 alpha genes out of 4 genes. Tetramerase, this is because the tetramerase of excess of beta chains. HbH has high affinity for oxygen, can produce intracellular accumulation, can lead to moderate to severe anemia. Hydrops fetalis, it's the most severe form of alpha thalassemia. Deletion of all the 4 genes are seen. Gamma 4 chains form the hemoglobin bards and has high affinity for oxygen. Fetal distress can be seen in third trimester of pregnancy. The babies can develop severe pallor, generalized edema and massive hepatosplenomegaly. Features are similar to those seen in erythroblastosis fetalis. So this is a picture where you can see a stillbirth with a generalized edema, as well as the patients might be having hepatosplenomegaly. Okay, thank you so much.